Slipped capital femoral epiphysis. It is also called as slipped upper femoral epiphysis as well. It is one of the most common hip pathology in adolescent age group. Usually, these patients usually present in the age of 10 to 16 or 18 years of age. And this is at the adolescent age, it's actually the most common hip pathology. And usually, whenever child or a young adolescent boy or a girl around 14, 15, 16 years of age presents to you with hip pain, the first thing you should be thinking of is SCFE. And what it is, why it's called as actually femoral epiphyseal slip. What happens is, as you know, the proximal femur has an epiphyseal region, then there is physis, and this is all metaphysis. The problem is with the physis, there's actually weak physis over there. There is structure called as perichondral ring around the physis, which is usually thin and weak in the patient who are more susceptible to slip. What happens is that the epiphysis remains in the acetabulum, it remains in place, but due to the weakness of the perichondral ring, when the mechanical factors are acting on the hip joint, for example, if the child is obese or there is increased load on the hip joint, what happens is that this physis starts to give way, and that gradually the metaphysis or neck of the femur actually starts to move more anteriorly in an external rotation. Once the neck starts to move in anteriorly in external rotation, what happens is when you get an X-ray of these adolescent children, what you see is usually that the head of the femur actually has gone more into posterior medial direction. But it's not actually the epiphysis which slips, rather it's the metaphysis which slips relative to the epiphysis. And when we get an X-ray, because if, for example, this is how the head was in and the neck has gone out and the head remains over there, this will look like that head has actually gone more into the posterior medial position. But the problem is of physis. Epiphysis remains in place, but the metaphysis goes in more of anterior and external rotation, which is the neck of the femur. And that is why this term is called as the slipped capital femoral epiphysis. Although this is a misnomer, it's not the epiphysis which slips, rather it is always the metaphysis which goes into anterior as well as external rotation. But it's been labeled as epiphyseal slip because when you get an X-ray, what the first thing you appear is that you see the the epiphysis has gone more posterior medially and slipped from the physis and metaphysis. Now there are different causes. As I told you, it's the most common hip pathology in adolescent age group. There are certain risk factors which may be associated. Although exact cause is not known, but the most common theory regarding the pathophysiology or pathomechanics of this disease is that there is actually the weakness of perichondral ring. And once the perichondral ring is thin and weak, mechanical load when is applied to the hip joint, this usually ring gives way, leading to this sort of situation in which the metaphysis slips from beneath the physis. And as it slips from beneath the physis, as a result, this slips starts to actually affect the nutrition of the physis, and then the whole cascade of problems starts later on. But whatever the next we see in terms of the patient's signs, symptoms, and even the complication of the disease are actually the cascade of event which starts right from the slips, and the main cause of the slip is always a mechanical cause, or it is can be called termed as a biomechanical problem because of the loss of perichondral ring over there. Then it can be briefly divided into the increased retroversion of the proximal femur. When multiple theories were there, according to some other authors, actually there is mechanical malalignment as well. For example, the normal anatomy of the proximal femur is such that it has a 10 to 15 degrees of anteversion. But instead of having anteversion, it had a 10 to more than 10 degrees of retroversion at the proximal femur. There was also retroversion of the acetabular cup. Now, if, for example, instead of having this kind of a mechanism, the cup is lying in retroversion, then the proximal femur has increased chances of coming out of the acetabular cup. Therefore, This malalignment complicated by increased mechanical loading as well as thin cortex and thin pericondylar ring all contribute to this problem, leading to slipped capital femoral epiphysis. Other causes could be the changes in shape of the proximal femur. As I told you, there is increased acetabular retroversion, increased femoral retroversion as well, and then there is significant lengthening of the femoral neck. Usually there is increased varus deformity at the neck level. The neck becomes length in more oblong shape, with the greater troch coming higher up as compared to the other side. Now this varus deformity further contributes because it actually raises the mechanical load on the physis, and with the physis already having a weak and lax pericondylar ring, that would further actually aggravate the problem, leading to increased slip. So with few causes of biomechanical malalignment with biomechanical instability, this actually leads to a vicious cycle in which the slip actually continues to progress and eventually becoming a very severe form of a slip, and patient may not be able to bear weight on the hip joint as well. Then the most commonly, as I told you, usually these children are obese. They have the obese children and hypothyroid children are increased risk, are more susceptible to development of this problem, because if there will be some form of malalignment, provided they were having a high weight, there will be increased biomechanical stress over the hip joint, and large body habitus actually produces that high biomechanical stress. With already factors in play, this actually accelerates the slip, leading to SCFE or slipped capital femoral epiphysis. And large body habitus is always accompanied by additional weight. Usually it's slightly more common in males as compared to the females, as well as that there is certain ethnicities. For example, in Afro-Americans, this is quite common, probably due to their increased tendency towards hypothyroidism and increased body weight of these ethnicities. Now, as I told you, the pathophysiology is such that it's actually sort of a misnomer. It's not that the physis has a problem, physis is lax, there is actually pericondylar ring is weak, with epiphysis stays in place in the acetabular cup, but the metaphysis goes in anterior as well as external rotation. And when you get an X-ray, it appears as if the epiphysis has gone more and slipped into a more posterior medial direction. And this is how it appears actually, that although the problem is in the metaphysis and metaphysis is going actually in another direction, but what it appears to be is that it's actually the epiphysis. If you see it over here, now you can appreciate that it's actually the epiphysis which looks like it's gone down or slipped down, but actually it's not that epiphysis has gone down, but this has actually gone more anteriorly and in external rotation, which actually gives us an impression as if the epiphysis is going more posterior medially. Now coming to the clinical presentation. As I told you, there are certain risk factors. For example, adolescent age group, Afro-American ethnicity, obese children, hypothyroid children, they have increased tendency of developing a slipped capital femoral epiphysis. The most commonly, usually when you ask the symptoms of the pain, the most common the symptom is always sometimes the knee pain. It's never the hip pain. Why it's the knee pain? Because the reason SCFE is missed early on is also the increased knee pain. The child of 13-14 years old, obese child, comes to you to another doctor and complains of knee pain. He assesses the knee, he gets an X-rays of the knee, and there's no pathology over there, gets analgesics and goes back home. But actually problem does not solve there. Rather, he continues to have a problem of pain and limp all along. Why this happens? Because usually the most commonly there is referred pain from the hip towards the knee joint, involving the obturator nerve or adductor branch of the obturator nerve. When this happens, the main pathology is not at the knee but at the hip joint. But most commonly the pain from thigh is referred towards the knee. Although in 1/3 of the subset of population, the primary pain is actually where the pathology is. That is, you have a pain in the thigh or the upper hip joint as well. Then it could be also groin pain, as which was the case in our patient. Patient was having hip pain, groin pain, as well as radiating towards the lower spine. Now this is where the differential actually starts to come in your mind, because if there is hip pain radiating towards knee, this could still be SCFE, but this still patient can present with the groin or hip pain which is radiating towards the spine. As I already told you, the most common pathology or most common presentation of pain in case of SCFE is not the hip but the knee pain, and that is through the adductor branch of the obturator nerve. Other causes and usually include associated endocrinopathies. For example, patient may have hypothyroidism, hypogonadism, or due to panhypopituitarism, and they may be associated with excessive growth hormone deficiency. All these patients with these problems of endocrine abnormalities are more susceptible to slipped capital femoral epiphysis. Now, as I told you, there are different associated disorders, and especially when you get, for example, in our case, the patient also, mother had a history of SCFE. So when you get that kind of a patient, you must rule out all the endocrine abnormalities on the history. You must ask about the thyroid problems. You must ask about the panhypopituitarism, hypogonadism, as well as renal issues as well. And the associated problems include hypothyroidism, because hypothyroid patients have increased body habitus, increased weight, therefore it increases the biomechanical stress on it, therefore that leads to increased slip. Similarly, excessive growth hormone deficiency. When these children actually present with excessive growth hormone deficiency, this leads to stunted growth, and a stunted growth leads to contractures, leading to eventually the increased slippage and increased chances of slip at the hip joint. Other associated problems is osteodystrophy of the chronic renal failure and panhypopituitarism. All these endocrine abnormalities increase and make the patient more susceptible to slipped capital femoral epiphysis. Now coming to, once we've taken the history and examination, then what about the physical examination? When we will be physically examining the patient, we will elicit certain signs so to make our diagnosis exactly to diagnose the patient and correct our diagnosis. What will be, we will be checking at the hip joint. We will be performing the Thomas test. We will be performing the Trendelenburg test. Why we need to do that? Because we need to make it sure whether the problem is at the hip joint or the problem is at the lower spine. Remember, in our patient, there was pain radiating towards the lower spine as well. But if Thomas sign comes out to be negative, this means probably this pathology is lower down and there is no associated contractures of the hip joint. Then why we need to go for Trendelenburg test as well, because we need to make it sure that there is no associated adductor weakness. Patient may have certain other associated pathology which may be leading to adductor weakness, and patient may be limping on that side as well. And then we check the range of motion of the hip joint. Why we need to check the range of motion of the hip joint? Because we need to exactly assess whether is there any associated restricted hip range of motion, like is there any restrictions on internal rotation or even external rotation, is there any restricted or extension or flexion at the hip joint, is there any restricted adduction or abduction at the hip joint. And usually if the child, the adolescent patient has a problem of SCFE, there is decreased internal rotation, decreased adduction, as well as some flexion pathology at the hip joint. Now this why when you will examine these patients, you will have increased abduction as well external rotation at the hip joint. Whenever we are assessing the hip joint, once we have made the patient lie on the bed, we make patient comfortable and lie supine, then the first and foremost thing is we assess a generalized look at is there any excessive external or internal rotation of any of the leg, is the both the patella are at the normal level, or is there is gross discrepancy of limb length, which as one limb is shorter as compared to other limb? Are there any other gross pathology or deformity which is very much visible from the on inspection as well? Once we have done that, then we go for the other examination of the hip joint as well. And then first thing is hip pain during motion. Is there any hip pain during the motion as well or not? Is there any snapping sensation during the hip motion or not as well? Now that will rule out other causes of hip pain actually. Is there any limitation to internal or external rotation? Are there any limitations to abduction, flexion or internal rotation or not? Because what we need to understand is that usually there is internal rotation deficit along with the flexion contracture, and there will be adduction deficit as well. That hip would appear as if it's in more an abducted as well externally rotated phase. Now we also have to check the Drummond sign. Whenever we are, for example, flexing the hip, usually the knee should always point out towards the opposite shoulder normally. But in case of SCFE, it actually externally rotates slightly, leading to that it points out towards the ipsilateral shoulder. For example, in our case, patient was having a problem with the right hip. If we would have Drummond test normally would be negative if when we are flexing the hip on the right side, the right knee is actually pointing towards the left shoulder. If that's happening, this is a negative test. But if there is increased external rotation during flexion and the right knee is actually pointing towards the right shoulder, this means the Drummond test is actually positive. Antalgic gait would be present. Our patient was leaning on towards the left side, was not actually putting a lot of weight over the right hip. Why? Because the problem was on the right side and patient was not feeling comfortable by putting their weight on the right side. Whenever the patient walks, usually the right sided, if the pathology is on the right side, the right sided stance will be shortened and patient will quickly go into the swing phase when on the right side. But when on the left side, the swing phase has usually the normal ratio, which is 2/3 and 1/3 ratio. And why this actually the stance phase actually decreases? Because the patient cannot stand comfortably due to the hip pain. Therefore, they walk more quickly and actually they have a enlarged swing phase rather than having a more large stance phase during their gait pattern. Then, as I told you, there may be associated with Trendelenburg gait. Continuous hip pain, involvement of gluteus medius and minimus may eventually lead to loss of abductors of the hip joint or abductor weakness, which may result in a Trendelenburg sign or Trendelenburg gait being positive. That is, when the patient starts walking, there is actually sway on the abnormal side, and this results in because the pelvis cannot actually bear weight when the patient is actually standing on one leg during the phase of this joint. So when we are assessing the hip joint, we have to ask the patient to walk, go few steps over there and then come back to assess the Trendelenburg gait, and then we have to perform the Trendelenburg sign to elicit whether is there any associated glutei weakness or not. And that is of the utmost importance because we have to assess whether the problem is the hip joint or is it at the spine level. So once we've done the history, we've done the examination, we should have certain differentials in our mind, and differentials should be then confirmed or refuted by the use of radiographs. First and foremost, we usually get an X-ray pelvis view, AP view with both hip joints, and when we get that, if we get this X-ray, usually if we can appreciate over there, then we can definitely see there is a change in the cleans line. What is clean line? This is the normal side. If you see it over here, this line which is on the just outer border of the neck of the femur should pass through lateral 1/3 of the head of the femur. Usually 2/3 is medial to it and 1/3 is lateral to it. This is a normal orientation. But as our patient was having pathology of the right side, if you appreciate it over, this is the outer edge or border of the right side of the neck. You calculate a line like this, you can appreciate it's just barely touching or abutting the neck. If this slip would have increased a little more further, usually what happens is that the whole head may be lying medial to it, and there may be no overlap of the line over the head of the femur. And in this case it was just touching, therefore means there is slip, but although it's still, slip is not that much that is actually coming all out, and the head has completely moved medially to the clean line. So one way of calculating it is that you calculate the clean line, and then there is another called as the Kapner's sign, or this metaphyseal blanch sign of the steel, or steel sign. There are different signs which you have to calculate. If you see it over here, this is the problem. This is an X-ray of another patient having a left-sided hip pathology. Can you appreciate the slip? Now this is the physis. This is what I was talking about, that usually you feel like as if the head has gone more posterior medially, but it's not the head which is actually, that rather the neck has gone more anteriorly in an external rotation. As a result, this head, if you see it over here, it's lying in the acetabulum and it does not go posterior medially. But if you see it over here, this is called as metaphyseal blanch sign of steel, because whenever pathology of SCFE is there is increased radio densities over the metaphyseal region. That is termed as metaphyseal blanch sign of steel. Now if you calculate clean line on this, if you see it over here, it's almost going like this. And if you appreciate, the clean line would be like this. Can you appreciate the whole head is no more medially as compared to the other line? Therefore, that's another indication that it's most likely going towards SCFE. Now coming to the Kapner's line. Now Kapner's sign is actually calculated. If you see it over here, that you can appreciate that normally this acetabular posterior edge, once we are taking the X-ray, all these threes are calculated on the X-ray pelvis AP view. This line over here is called as the posterior edge of the acetabulum. This usually appears to be slightly medial to it, but if you see it on this pathology, the head is actually all the way lateral to it. Sometimes if there is increased slip, the whole of the head is actually lateral to this, the posterior edge of the acetabulum, and this is called as the Kapner's sign. All these signs are actually telltale signs of SCFE, and that means the diagnosis is going towards the SCFE. Otherwise, if you see, you have, as there was history of coccyx fracture, therefore you can look at the coccyx bone as well, but usually it may at max is going to show a malunited fracture of the coccyx bone. That's it. Now when we are calculating the slip, we have to actually grade the slip. Grading of the slip is very important, and for that we have called as the Southwick angle. For example, this is another, if you see it over here, this is the head, this is the physis, and this is the metaphysis. Now what we do is we take the one point at this level and one at this level, and we join it together. Now this is actually the epiphyseal axis. This is the epiphysis, this becomes the epiphyseal axis. The other line is at 90 degree or perpendicular to the epiphyseal axis at this point. If you can appreciate over here, this is the epiphyseal axis, the line is 90 degree to the epiphyseal axis. This line is called as the anatomical axis of the femur or the neck, because its sign is taken at the center of the neck, and this is how it is actually coming as a femoral axis. Therefore, the point which is being joined over here is termed as Southwick angle. But for example, if it comes out to be, let's say, 60 degrees, we will not mark it as Southwick angle of 60 degrees, because what is important to understand is that you have to calculate the normal side as well. And normally angle is about 10 to 12 degrees. If the other side is not involved, you will calculate it up to normal angle, and if this angle comes out to be of the involved side up to 60 degrees, then you have to minus the normal angle. That is 60 minus 12 would mean the actual angle on this side is 48 degrees. It's not 60 degrees. So that is which is very important to understand, and usually these x-rays and angles are actually calculated on frog leg lateral views. You get the frog leg lateral views of both sides. For example, our patient had a problem on the right side. You get it of frog leg lateral views of the right as well as of the left side as well. You calculate the angle on the normal side, that is on the left side as well as on the right side, and then you minus the normal angle from the right side and you get the actual slip angle on the right side. And then you classify whether it's a minor slip, that is the less than 30 degree, moderate slip, that is 30 to 60 degree, and if it's more than 60 degree, it becomes a severe slip. Then we have different ways of classifying a disease. There are multiple classifications which are available for SCFE. For example, one way of classifying is temporal classification. Temporal classification is based actually on the time period or time which has elapsed for the duration which has been for the disease has been present. Usually it's called as acute if the slip has been less than 3 weeks. It can be called as chronic if the slip has been more than 3 weeks. Another way of classifying it temporally is acute and chronic if there was acute exacerbation of symptoms in less than 3 weeks over a problem which has persisted over chronically. Therefore, we can call it acute and chronic slip as well. Therefore, when we temporal classification divides it into 3 forms, that is acute, chronic, and acute and chronic. The next form of classification is a clinical classification. Clinically, we assess the patient, how much hip pain is there, how much stability of the slip is there, and is the patient able to bear weight or not. There is a Loder's classification which is there to assess the stability of the slip. This is the hip is termed as stable if the patient is able to bear weight either completely or with the help of crutches or orthosis. If the patient comes and says that I'm able to bear weight, no, I can walk around, but yes, I do feel some pain over there in the hip joint. Or the patient says I can walk around, but with by use of a cane and a crutches, then this is still a stable slip. If the patient comes and says that I'm unable to bear weight, whether without any aid as well, even if I use a cane or crutches, I'm still not able to bear weight due to the pain of my hip joint, then most likely this is an unstable slip. Other form of classification is this is called as the radiographic Southwick angle. Now, radiographic Southwick angle, as I've already told you, that you get frog leg lateral views of the both sides, and then you normally as frog leg lateral view, the slip should be around 10 to 12 degrees. This is a normal value. If it's bilaterally involved, then you calculate it on the both sides and you minus 12 degrees from both sides. If, for example, one side is involved, you calculate the normal side first, then you calculate a slip angle on the involved side, and then you minus the angle of the normal side from the involved side, and you actually calculate the relative slip or actual slip angle which is present on the involved side. That is all radiographic measurements so that we can differentiate from mild, moderate, and severe form of a slip. Mild slip is when the angle difference is less than 30 degree. Moderate slip is when it is from 30 to 60 degree, and severe slip is when it is more than 60 degree of a difference between the normal and the abnormal side. Then there is also called as radiographic lateral slip grades as well. It can be divided into 1, 2, and 3 grades. There are actually that classification is based on the slippage of grade. How much slip is there? If the slippage from less almost 0 to 33%, this is termed as grade 1. If slip is from 34 to 50%, this is termed as grade 2, and more than 50% slip is termed as grade 3. So there are different ways of classifying the SCFE or slipped capital femoral epiphysis. And I've almost explained all of them, that you have to calculate the Southwick angle, you have to calculate the grade, you have to assess the patient clinically, as well as you have to do the temporal classification to see how symptoms have been present for how many days, weeks, or even months as well. Then comes, once we have diagnosed the patient with SCFE, that is the patient is having slipped capital femoral epiphysis, then what is the treatment? The ideal treatment is called as in-situ pinning. Why it's termed in-situ? That is that you do not open the joint. For example, if you see it over, there is a left-sided slip. One way is I can appreciate that my neck of the is in more external rotation and interior, but I will still not reduce this joint. Why? Because the medial circumference femoral artery, there is an anterolateral branch of it, which is actually just winding around over the superior lateral edge of the head of the femur. When we reduce the slip, this may lead to kinking of this artery and involvement and leading to problems of the vascular supply to the femoral head. And as we know that in adult age or from adolescent age, the major supply to the head of the femur is through the medial circumference femoral artery. Therefore, the method being done to actually fix this problem is in-situ pinning, that whatever the slip is, let the slip be, just fix it and make sure that there is no further progression of slip, whatever it is, whether it's mild, moderate or severe. Therefore, the first line treatment is called as in-situ pinning. You just fix it, whatever the grade of slip is, and just make it sure that this slip does not further progresses. Now coming to whether we have to do it on the one side, whether we have to do it with the one screw or the two screws, there is actually a lot of debate going on. It's still controversial to use two screws. Why? Because usually there is not much space available in the neck, and when you get, for example, if you put the neck screw on the left side, if you are putting another screw, you will probably put it more superiorly and laterally. And we are actually already we know that there is superior lateral branch of the medial circumflex artery which can be damaged by putting in the screw. Therefore, that will actually lead to avascular necrosis. So usually it's said is that you go with in-situ pinning, usually with one screw on the affected side. But when to go with bilateral in-situ pinning? Do we need to go for the other side as well? For example, if the patient does not have a slip on the other side, our patient has a problem on the right side. If the patient does not have a slip on the left side, should we have gone for in-situ pinning of the left side as well? So that is something which actually it's an important question, because you have to actually answer if this patient, our patient's age was around 17 years. If the same patient with the SCFE would have presented, let's see, at 8 or 9 years of age, patient would be obese, patient would have an associated history of hypothyroidism, hypoparathyroidism, or even hypogonadism. Then there is endocrine abnormalities, obesity, and early age of onset or early presentation that actually preludes that you should also go for prophylactic fixation of the other side. If the same patient with the right side pathology would have presented early with endocrine abnormalities and obesity, then we should also prophylactically fix the other side, which in our case was the left side. But if the patient has presented late, there is no associated endocrine abnormalities and there is no obesity, then probably we don't need to go for the prophylactic fixation. Probably we can go for the fixation which is actually required and only on the involved side. And why is actually this done? There is a reason behind it. Usually, if there is increase weight or obesity, early age of presentation, for example, child presenting at 8 or 9 years of age, now the pubertal spurt has yet to come. And when this child will be undergoing that pubertal spurt at 12, 13, or 14 years of age, already the child has risk factors. There is hypothyroidism, there is obesity, there is actually growth spurt is still left. Therefore, there will be increased mechanical stress and patient will eventually develop bilateral slip on both sides. To prevent actually the development of that slip during the pubertal spurt, that's why we go for prophylactic fixation of these patients if they present early and with associated risk factors. Otherwise, if the child, in our case, the patient was 17 years of age. At 17 years of age, he has already crossed his pubertal spurt. Therefore, if the problem is not on the left side, we don't need to fix it, because the patient has already, if not developed yet, probably patient will not develop the slip on the left side, because pubertal spurt has the increased chances and increased risk and therefore these patients are usually during the pubertal stage they develop the slip most commonly. Now coming to in-situ pinning of bilateral, as I told you, when do we go for bilateral? When we have early age of presentation, a hypopothyroidism, obesity, or panhypopituitarism. Then there associated endocrine abnormalities. You go for the in-situ fixation of the involved hip as well as the prophylactic fixation of the opposite hip, and we can do it similarly in-situ pinning. That is, we do not reduce the do close reduction or even open reduction, and we just fix it in whatever the position it is available. If you see it over here, the slip is on the left side. Can you appreciate on the right side it looks okay, but on the left side it looks a little different. Similarly, on the right frog leg lateral view is like this, but on the left side it's like this. We have not reduced the epiphysis, rather we have fixed it in whatever the position it was, and so to prevent the progression of the further slip. Now coming to the treatment of open reduction, there is usually it's not done and it's not advocated because during open reduction there is increased chances of damage to the vascular supply, which may eventually result in avascular necrosis, which we were actually trying to prevent initially. Because slippage would, if the femoral epiphysis will continue to slip, this would result in loss of vascular supply towards the epiphysis and eventually leading to AVN. Therefore, our main goal was still to actually save the head from developing AVN. And if we are going with open reduction, usually it's not done, but it can be done in certain situations. For example, if it was a high grade slip, child has attained the age of post-pubertal stage, that where open reduction can easily be done. And that's, we can still go with open reduction and we can reduce the head and apply screws and K-wires, as you can appreciate it over here in the AP as well as the lateral view. Then if it's a chronic case, or if this has been neglected for quite a long time, then we have certain other options available as well, which includes actually the osteotomies. Now there is a called as Ganz technique, in which the open reduction, first you open the patient up, you surgically reduce the reduce the hip. Once you have surgically dislocated the hip, then you reduce the head back, then you reduce it by open reduction, and then apply actually screws and plates towards the proximal femur as well as the neck of the femur. This is called as via Gibson approach. In this, they have actually first doing the surgical dislocation. This is the metaphysis, this is the femoral, this is the epiphysis. They're doing the surgical dislocation. They're making sure whole of the hip is actually dislocated first, and then once it's dislocated, this head is positioned and hip is actually reduced by open reduction method. And once it has been reduced in its place, then the screws and K-wires can be used to can be applied, and maybe a plate may be applied over the proximal femur as well. Other options include proximal femoral osteotomies. As I told you, there are different pathologies which may eventually develop because there is decreased internal rotation, there is abduction contracture as well as flexion contracture. This leads to increased coxa vara, or that's called as decreased neck shaft angle. Now when neck shaft angle is there, then we have to go for valgus derotation osteotomy at the proximal femur. In the case of femur, we have to go for valgus derotation because that is going to produce flexion, adduction as well as valgus angulation at the proximal femur joint, because these are actually mainly limited in the case of SCFEs. There are different osteotomies which can be done. One is called as the modified Dunn procedure, which I've just appreciated. The modified Dunn procedure is that you surgically dislocate the hip joint, reduce it back, and then once you have reduced the metaphysis back in, you can apply the plate and screws to the neck as well as the proximal femur. Or Dunn osteotomy can also be done at the level of the neck of the femur. Then that is called as a Kramer osteotomy. If you see it over here, this is the epiphysis, this is physis, this is the neck. Now, if this area is called the subcapital neck area or cervicotrochanteric region, if the osteotomy is done to correct the deformity at this level, this is termed as Kramer osteotomy. Then other osteotomies include Southwick. This is called as intertrochanteric area. If it is done below the level of intertrochanteric area, this is called as Southwick osteotomy. If it is done at the level of intertrochanteric region, it's called as Imhauser osteotomy. And then there are late osteotomies which can also be done around the periacetabular region as well, because as I told you initially, there is some mechanical problem associated with increased femoral retroversion as well as the acetabular retroversion as well in the case of SCFE. Now, as I told you, done osteotomy can be done. This is just an X-ray of the preoperative slip. Once they have done the osteotomy, that is at the level of the neck, applied the K-wires, and usually they are smooth K-wires because proximal femoral epiphysis has to be preserved, and using screws can damage the physis of the proximal femur. Other option is having a Kramer osteotomy, and Kramer osteotomy is done at the neck and trochanteric junction. This is at the cervicotrochanteric junction. We can produce this osteotomy to actually correct the increased neck shaft. We can correct the decreased neck shaft angle at the proximal femur. And then other options are Southwick osteotomy and Imhauser osteotomy. Imhauser osteotomy is, as I told you, is done at the intertrochanteric level, while Southwick osteotomy can be done at the subtroch level. Usually these are flexion producing, internal rotation producing valgus osteotomies, which are usually done in the proximal femur. Why? Because whatever the region it is, it's usually the problem is that there is loss of internal rotation, there is loss of adduction, as well as decreased neck shaft angle. So you have to reduce form of valgus angulating osteotomy to correct the varus which has been produced at the proximal femur. Similarly, you have to produce a flexion producing as well as external rotating osteotomy, because that would actually correct the internal rotation which is actually deficient at the level of proximal femur. Other osteotomies could be the late osteotomies, which can be done at the level of proximal femur. For example, proximal femoral shortening osteotomies can be done if this is associated with increased limb length discrepancy, as well as we can go for acetabular osteotomies as well, because to correct the increased acetabular retroversion and femoral retroversion as well. Now, as I told you, there's always the valgus producing derotation proximal femoral osteotomy, which can be done. Now this has been done, this is called a Southwick osteotomy, and done at the subtroch level, that the varus has been corrected, and this is the osteotomy has been done at the subtrochanteric level, and then a blade plate has been applied so that the osteotomy can be held in its place after the surgery. This is the AP peroperative fluoroscopic view, and this is the lateral view of the same case. Now, once we go for surgery, there are always associated with some complications. Remember, there is no management such as conservative management in the case of SCFE. Either you go for in-situ pinning, which is minimally invasive, closed sort of a in-situ pinning, or you have to go for some open procedure in form of osteotomy as well. And whenever you are going for open procedure, this is usually associated with some complication. Most commonly, the most common complication is actually the avascular necrosis of the femoral head. That screw may disrupt the vascular supply, or for example, when the K-wires are inserted, may damage actually the medial circumference femoral artery. The next is always the chondrolysis. When we are putting in the metalwork, sometimes the K-wires penetrate the epiphysis as well and actually damage the hyaline cartilage over the head of the femur. This may eventually later on produce chondrolysis and chondromalacia. Then other problems could be the early osteoarthritis, that because of the increased instrumentation, this may lead to damage, and early osteoarthritis may be produced in the affected hip. Then furthermore, our surgery can be unsuccessful. This may lead to increased progressive slip. The patient may still have a problem of such as non-union or malunion, or there may be problem with such as infections as well, or even because these screws are not very hard, and if the patient starts early weight bearing, this may eventually lead to screw breakage or hardware failure as well. All these problems can be actually associated with the surgery of SCFE. In this lecture, we have briefly covered hip pathology, which is one of the most common hip pathology in adolescent age group. We have covered slipped capital femoral epiphysis, how it presents, associated with usually painful limb and mainly on the one side. The main risk factors include hypothyroidism, opacity, and hypoparathyroidism. While usually if the patient does presents and patient presentation is early onset, there is associated opacity or hypopituitarism or hypothyroidism, then we go for bilateral in-situ fixation of the both hip joints. But if the patient does not have any of these risk factors, the first and foremost treatment is in-situ fixation of the involved hip. We can go for certain osteotomies, but that is only usually for moderate to severe form of a slips, in which the angle is either more than 30 or more than 60 degrees of the south pec angle. And usually the osteotomies are done at the level of subtroch or intertrochanteric level. Although we can go for osteotomies at the neck as well as cervical neck and trochanteric junction as well. Thank you very much. Keep watching sqadia.com.